Hi everybody, I'm Dr. Goebel-Fabbri. I'm a clinical psychologist and I specialize in eating disorders and type 1 diabetes. I've been working in the field since 1999 when I started at Joslin Diabetes Center, and about 5-6 years ago I left Joslin and started my own private practice, and at that time I also wrote a book about recovery from diabetes, from eating disorders in diabetes, called Injecting Hope. It's published by Routledge Press. And here are some of the questions. How long have you been working with people living with diabetes and how long have you been working with people living with type 1 diabetes, and what inspired you to devote your attention and research to EDDMT1? So EDDMT1 is just sort of the academic community's descriptive term for eating disorders and type 1 diabetes instead of using the term diabulimia. I went into psychology actually not with any intention of specializing in diabetes. I did have an interest in eating disorders for some personal reasons. My closest friend in high school developed anorexia, and I was one of the first people who noticed it and got very worried about her and her health, obviously. When I went to college, I knew that I was going to major in psychology, and the only clinical professor that we had on our faculty happened to be an eating disorder expert. And so I was lucky enough to train under her, and then to choose to train at Beth Israel Deaconess and Joslin Diabetes Center in Boston, where I picked the worst number out of the hat. There were 5 of us interns at BI, and we were all women, and we could choose from 5 different health psychology rotations. And one of them was women's health and infertility, one of them was eating disorders, one of them was chronic pain, cardiac rehab, and then there was this brand new one at Joslin Diabetes Center, which was going to be in pediatrics. And none of my fellow interns had any pediatric experience, and none of them wanted to do the newest rotation. So when I picked number 5 out of the hat, I got the quote-unquote worst intern site, which was Joslin, and I ended up falling in love with the field. I knew that there was some early research that my professor at college had done with the Yale Eating Disorder and Diabetes program, and so when I met with my mentor at Joslin, I said, "Hey, is this something that might present as a need here?" And she said, "Absolutely." And we cobbled together her as one mentor and an eating disorder specialist as another mentor, and that's sort of how I created this hybrid and very unusual specialty, which I always make the joke, if you're willing to work longer hours for free at Harvard Medical School, they're happy to let you do it. So that's how I ended up getting that specialty. I think the reason why I find it so compelling, though, and why I love it so much is that this really represents an underserved population. It's clear that there's tremendous need, and also that very few providers in the mental health field and very few providers even in the diabetes field understand it well enough. And so that's why I find it compelling. I just think it's such an important area, and such an important area for growth and for writing and for making people more aware of the issue. Second question. Have you come across any shared misconceptions or myths from your patients living with type 1 diabetes who are working on recovering from an eating disorder? I would say the first myth is that if you have an eating disorder and you have type 1 diabetes, it means that you have to be manipulating your insulin, which is absolutely not the case. Clearly, the research, the bulk of the research and the emphasis of treatment is on those patients who do reduce their insulin for purposes of calorie purging, because they represent such a medically complicated clinical picture. But That's not to say that everybody with an eating disorder and type 1 diabetes has that particular symptom of insulin restriction. You can have all the diagnostic categories, for example, of anorexia nervosa, and slide right under the radar because you're not changing your insulin needs necessarily, and your blood glucose may be in, healthy range, and you may be getting all these kudos from your diabetes team and from your family and loved ones about, managing your diabetes so well, and in fact, you're starving to death. So eating disorders can show up in any kind of symptom picture in type 1 diabetes, not always, and certainly not exclusively with insulin restriction. Oh, I've also had people say, because of the term diabulimia, I had a patient say to me, well, I can't possibly have diabulimia because I don't make myself vomit, because she thought that if it was bulimia, it meant that it had to involve self-induced vomiting. Now, clearly, there's a much more powerful, much more dangerous calorie purge in terms of insulin restriction. And so for those patients who are using insulin restriction, they don't, quote unquote, need to make themselves vomit because they have this far more dangerous, far more dramatic route for calorie purging, so to speak. The last myth, I would say, well, there are several others. I guess another myth is that eating disorders only happen to teenage girls. And that's a myth that's sort of pervasive in the culture and has nothing to do with diabetes per se. But men can have eating disorders. Adults can have eating disorders. It doesn't necessarily start in adolescence. It often does, but it doesn't always. So I have women who are in middle age who develop eating disorders in their midlife. Or maybe they just present to treatment at that time. But to say that this is sort of like a white, wealthy teenage girl's disease is no longer accurate. So that's certainly a myth. And lastly, I would say that some patients feel like they can't possibly have an eating disorder because they're not skinny enough. In other words, their bodies haven't wasted to a point of dangerous thinness, and so they feel like they're not sick enough to really sort of warrant that diagnosis. And that's just not true either. I mean, when you have type 1 diabetes, the complexity of eating disorder symptoms in that context is so dangerous and so medically complicated that you merit treatment no matter what's going on with your weight. Your treatment is medically necessary and seriously indicated. What do you think are some of the hardest things a person recovering from an eating disorder in diabetes struggles with during their first year of recovery? Gosh, I was thinking about this. I think the first challenge really is the most fundamental challenge, which is finding a treatment team, finding a group of treaters that can work together with each other and work together with you in partnership so that you feel like you're understood, you feel like you can be open and honest with your treatment team. They're not going to judge you, they're not going to reject you, they're not going to kick you out of their practice. They want to support you, they want to understand what's going on. I think that's the hardest sort of first challenge. How do you find those types of treaters to work with? I think the second challenge is, how do you find treaters who, if they're not necessarily experts in this particular area, how do you get treaters who are willing to learn about it? I think you need to have treaters who are humble enough to understand that they don't know everything about type 1 diabetes, that they can learn from the endocrinology team, not from you, the patient. You don't owe it to them to teach them about your diabetes. They owe it to you to learn about your diabetes. So I think that has to happen in collaboration with the diabetes treatment team. And I think the diabetes treatment team also needs to be humble enough to understand that they don't know everything about eating disorders, and that they can collaborate with their mental health colleagues to learn more about what's going on from that end of things. So I think having an open discussion, not only from the patient to the provider side, but also provider to provider, being open and having solid communication is really, really important. I think once you've got that in place, then what's probably the next absolute hardest piece is taking that leap of faith. And if you're engaging in insulin restriction, starting to take bolus insulin again, or starting to take basal insulin again. I think committing to staying out of diabetic ketoacidosis, committing to staying out of intensive care and out of a medical crisis is that first critical step. And it's made so much harder because typically the person's body has been in a state of profound dehydration because of high blood sugars. And now with appropriate hydration and appropriate insulin, that body sucks in that water and hangs on to it. It's called insulin edema. People feel very swollen. They can feel like they've gained a lot of weight very, very quickly. And while it's true the number on the scale has gone up, it's not permanent weight gain, it's water. And it will go away. What's required is you've got to give yourself plenty of hydration, don't take diuretics, don't take too much caffeine, and make sure that you're working with a team who can support you and remind you this is not quote unquote real weight gain. It feels like weight gain, it may even look like weight gain, but it's going to pass. And it will pass. It's just very hard because nobody can predict exactly how long a person's body will take to recover from that. I think another thing that makes it hard in that first year is trying to figure out what your body's insulin needs are actually going to be. Because what happens is if your numbers have been high for a very long period of time, you can't safely suddenly go down to a healthier range. That's not safe to do. You have to do it very gradually and slowly over the course of several months, which will help actually to mitigate some of that swelling. If you can do it more gradually, the swelling will be less dramatic, but it's too jarring on the body. It's not safe, and it can actually create what's called treatment-induced diabetes complications if you lower your blood glucose too rapidly and too dramatically. So pacing yourself, once you feel ready for change, pacing yourself is oftentimes very difficult. To try to do it slowly, to try to be gradual about it, to not try to aim for perfection. It sort of flies in the face of everything you've learned about diabetes your whole life. You got to get lower, you got to get lower. Well, no, you got to do it slowly and carefully. And then trying to figure out, okay, so what amount of insulin is going to take me down gradually to a healthier range, and what will be the amount that helps me stay there? Because you may require less insulin once you're in a healthier zone than you did when you were first trying to break through that insulin resistance from high blood sugar. So it takes a lot of finessing and a lot of sort of working back and forth with your treatment team to try to figure out what's enough insulin to keep you in a healthy range and what's not too much insulin that you're having to feed constantly even when you're not hungry, right? That's just going to lead to you being terrified about weight gain, and that's not going to be a helpful thing either. So finding that balance, I think, is really important. Are there things that can make some of these obstacles easier to overcome? Well, I think, first of all, places like organizations like We Are Diabetes are a huge source of support and coaching and even referral sources for patients who are in this struggle and who are trying to make it toward recovery. So accessing that kind of support, I think, is incredibly important. And it's why I love being able to work with this organization. I think being able to get reminded by your treatment team and by your loved ones that you're doing this well, that you're doing the best you can, that this is a long process, it's not a short sprint. I think all of that is really helpful. And I think working with a team where you know that they understand your concerns about weight gain, they understand what you've been struggling with, and they're taking it seriously. They're willing to work with you in a collaborative, productive kind of way. I think that's the most critical factor here. Okay, so the question is that in my opinion, social media has provided a very negative and defeatist outlook on fully recovering from ED-DMT1. Do you have any stories of triumph that you can share with us? Well, two things. I think social media actually, I want to give some kudos to social media actually in this case. So in eating disorders outside of the world of diabetes, these groups sort of pop up periodically that are called pro-ANA or pro-MIA groups, and they're sort of these underground groups that that try to teach how to become a better anorexic or a better bulimic. Pro-ANA is they're pro-anorexia, pro-MIA is pro-bulimia, and they're really toxic groups. They wreak all kinds of havoc for people and are absolutely not a healthy kind of support group in any form. And I think in diabetes, we actually have a very different model where there are groups like we are diabetes right here that are really plugging away at increasing awareness and at providing support, providing reliable guidance and some awareness training for professionals. And I think that has been a real boon for the diabetes community, and certainly for the diabetes community that's online. In terms of stories of triumph, I guess I would have to put in a shameless plug for my book. My book, I interviewed 25 women who all were stories of triumph. They were all in recovery from very severe eating disorders in type 1 diabetes. They all had very different routes toward recovery. Some had multiple experiences of inpatient treatment or residential treatment. Some had sort of fragmented care where they lived in rural areas and didn't have the same access to expertise. One person actually recovered through an online support group. And even though they all sort of came at this from different angles, they really shared some common threads of strength and resilience and of realizing that their lives were worth more than they had been allowing themselves to feel, that they deserved health, that they deserved wellness, that they deserved to have a chance at life, which their eating disorders were really robbing them of. I mean, one thing that's so clear is that when glucose is high from insulin restriction, people are not thinking clearly. They don't even feel things the same way. They sort of describe, I'm in a blood sugar fog, or I feel numb, or I feel like I'm at a distance from others. They feel sort of separate from the rest of their community. And by starting to get their health back and by engaging in recovery, these women really spoke about kind of almost like a rebirth, like coming back to life and re-engaging in the world and being able to give back in meaningful ways. So they are stories of triumph, and one of them actually was a patient that I had seen at Joslin for quite a long time, and was the patient was leaving the Boston area, and I was absolutely convinced that that she would not live, that she would not make it, that she was going to die young. And I saw her, I guess, 10 years later, because of recruiting her for the interview for the book. She volunteered from an online questionnaire, and it was just so wonderful to see her and to hear her story. And she has no complications. She's healthy. She has a successful career, a graduate education, a healthy family. It's really a story of triumph, and it just goes to show, like, there is no predicting this stuff. You can study it all you want. I'm saying this to myself. I can study it all I want, and I have no crystal ball. Like, people are a lot stronger than we know, and a lot stronger perhaps than even they know. So that really was a story of triumph that I love to share. All right, thank you so much for the interview, and thanks for letting me share a little bit about my experience. Take care. Bye.